Hi, everyone. Good evening and welcome to yet another edition of DynamicCIO LinkedIn Live. Unlike our Women in Tech series, this one is a specialist approach where we invite experts from a very specific industry vertical. Today, we have two very refined and very well-known experts from healthcare industry, whom I will introduce in a short while from now. While we wanted to keep the discussion very generic. However, facing the harsh times, it's very hard to keep COVID-19 out from any sort of discussion, whether it is political, economic, technology, or even for that matter, gossips. Um, Now, before we start our discussion, with the two distinguished experts that we have on the show, let me give a little background as to where we stand today. As on date, we are at 9.5 million cases, out of which, thankfully, 8.97 million have recovered and are healthy. Unfortunately, there have been around 139,000 casualties reported due to the deadly virus. Now, from a peak of 97,000 plus cases in a particular day on 17 September, we have climbed down to about 36,000 average daily cases, which is not a very good thing, but yeah, half of what we were clocking. At first, it seemed that India has been sheltered from this pandemic. Early action to restrict international travel by the government and state level precautions seem to have held back the floodgates of widespread infections. But as the time elapsed, as the time passed, number of cases kept ticking upwards, and we became the second most affected nation after the US. While we are technically behind the US in COVID-19 infections, numbers from the rural communities may be severely underreported, as we know, for whatever reasons. Uh, However, tests were ramped up with well over 1 million tests that we are conducting now, which is on par with the number of tests done in the US a few months ago. Now, if I spend a minute or two on the state of medical facilities and healthcare system, it will only be prudent and appropriate for the sake of today's discussion. Despite immense funding and efforts from both public and private entities, the continued lack of medical investment and healthcare infrastructure presented a great deal of challenges in mounting an effective response in India's fight against COVID, with about 8.5 lakh hospital beds, 8.5 hospital beds per 10,000 citizens, and 8 physicians per 10,000 citizens of the country. Our healthcare system is actually not equipped for such a crisis. Moreover, the significant inefficiency, dysfunctional in most part of the country, an acute shortage of the healthcare delivery system in the public sector do not really match up with the growing needs of the population. That's a fact. We cannot run away from these facts. In addition, more than 80% of the population still does not have any significant health insurance coverage, and approximately 68% of the Indians have limited or no access to essential medicines. Um, I may be presenting a very gloomy picture right now, but that's the reality we have to face. Now, among many initiatives, there's one which probably has the potential to help us overcome this wide and huge gap, which is also often talked about in various forums, whether it is government or private. It is about digital health or technology-enabled health, especially during and after the high intensity of COVID-19. We not only saw the impact of digital and tech-enabled healthcare, but also in a way felt its need on a very widespread basis. So with that, let me introduce and welcome our guests for the session today. I have the pleasure of having Arvind Sivaramakrishnan, Group CIO, Apollo Hospitals, and also Dr. Saurabh Lall, Head of Medical Operations at Max Healthcare. Welcome, Arvind, and welcome, Dr. Saurabh.
Pleasure talking to Rahul and Shipra.
Thank you. Yeah, with me, I also have my co-host Shipra Malhotra. She's the editor of the the Greyhead Media websites. So the bigger, I will start with a generic but a very pertinent question to both of you, starting with you, Arvind. Then Saurabh, you can also answer about it. The bigger mission of population health management came under tremendous stress during these last 6 7 months since the outbreak of pandemic corona. How would you interpret it from a medical practitioner's point of view, from a technology practitioner who's working in a healthcare system? Where did you find the most stress, and also in a way the most lacuna in the healthcare delivery during this time?
Well, stress as in the systems that the conditions that led to this pandemic was obviously spiraling in terms of time, the urgency, and the panic that was caused. Furthermore, to be fair, no one had a real medical explanation of what was going on and what could happen. Uh, so, if I can, put it in a very statistical or a mastic manner, it is the fishbone diagram was absolutely not known to anybody in terms of the cause and the effect, and things were playing out on a daily basis. So that was the crisis, so that immediately put into the desperate need of the population health management. So, from a standpoint of what is the lacuna, that means that we've not been in a disciplined manner of going through such like population health management and making decisions based on data and insights. That's not been part of our decision making culture. You know, our decision making culture has been based on experience, definitely evidence also, but here neither was there experience nor was there evidence because everything is new to everybody. So that was causing concern. And the second aspect is the culture of collecting data and disseminating data with a structure of health analytics. That as a culture, as a science, as a discipline, as a technology, all that into large scale usage was not there. I'm not talking of proofs of concept. I'm not talking of the availability of technology to do all of that. All of that existed, has been in existence for many years in the past. Maybe last 30 years also would be an understatement. But something that has been put to use in this scale and model, the data science behind it, the clinical science behind it, the statistical analysis and modeling behind it, to look at retrospective and look at prospective and look at it at time frames that are congenial to the nature and the growth of the pandemic. So this is not where we had a lot of time. So all of this, I think, was a sudden need put on the entire ecosystem, the technology ecosystem, the medical ecosystem, and the research and education ecosystem. Everybody was, presented with this thing. But to be honest, again, I think the manner in which the country, the people have responded to this. No, I'm not going to present such a gloomy picture of things becoming bad. And no, not at all. I think the scale to which we responded, the scale to which we showed that this is possible with the level of maturity. Again, I'm talking of sustainable maturity, not a proof of concept. So I think that gives me a lot of hope that the scale to which we need to do in terms of capacity building in all aspects of our health delivery, including technology enabled insights that guide decision making, that may guide treatment patterns. I think we've got a solid step forward. We, of course, for the scale and size of India, what we have done is still a small step only, but I think a very large small step in the right direction.
No, I completely agree with you, and there's no question on the credibility and the sincerity of the efforts made, and to this gigantic, widespread population in geographies where accessibility itself is a big challenge. I think it was a, it, you made a fair point there, that it actually raised the hope, and if we put technology ahead of all of these things, maybe the results are somewhat very starkly different. So Dr. Lall, your initial comments on the question that I asked.
So basically, I would put it, pretty much similar to what Arvind said, and it's interesting. I was sitting with the lung transplant team of my hospital this morning, and we happened to do a lung transplant in a COVID patient day before yesterday, and we were just discussing, and we realized that we haven't done very badly in this pandemic. So I always remember the initial days when COVID started, and our preparations were for a sprint race. And we said that it's a 3 months thing, so we rostered doctors, and we had the nurses on board, etc., so on and so forth. But then 3 months into the system, we realized that this is a marathon. So we started preparing for a marathon, and then running that marathon across 6 months, 9 months. Now we have got into a phase where we know it's a relay race. So this is going to continue, and we need to pass the baton effectively and efficiently. A lot of process excellence initiatives came in when we suddenly realized that we utilized all of our staff in the first 3 months and didn't really have people to go into COVID duties, which are very taxing, by the way. So we suddenly realized that wait, we need to step back and plan it up for the next not 6 months but probably a year. And there was no clue on how the trend. There was technically no trend analysis. In fact, our organization was one of the first organizations to start plasma therapies and remdesivir, etc. And hence, I believe that the pandemic has taught us a lot in terms of the healthcare industry in the country. And I think the biggest learning for me as the head of operations is that whenever something comes, we should act in a short-term, medium-term, and long-term manner, because we over-expected. In fact, it also reminds me of something very interesting, which I relate to the Cobra effect. So, all those who hail from Delhi would relate to this. The Cobra effect is something which happened in the Mughal era. And the Delhi region was, the old Delhi region was, surrounded by forests in the Mehrauli, etc. region. And there were a lot of cobras in that region. So the British government at that point in time rolled up a policy wherein they said that there are so many villagers, so many Indians who live in that area. Whoever kills a cobra and submits the head of that cobra will get a gold coin. And interestingly, what happened is that over a period of time, the number of cobra heads kept increasing, but the cobras never went down. So the cobras didn't die, but the heads kept increasing. And it's interesting to know that while we were on our journey, I suddenly, and the reason for that is that people actually started rearing cobras in their houses, so that they would rear cobras, cut the heads, and take the gold coins. So, that is exactly what happened in the pandemic, that we started off as a sprint and then suddenly realized that, every other business in the world makes no sense, and every Tom, Dick, and Harry started manufacturing sanitizers and face masks. And so it was quite interesting and very turbulent in terms of the way it spanned out. But I think over the last 6 months, we've really matured, not just as an organization, but I would say as an industry, as a country, on how we need to handle it. People have become more mature. I remember people calling in the initial days saying that, we want a single room, our services are poor. And today the situation is where people say that, yeah, it's okay if whatever's available, we have. I mean, I was just getting a call from one of the minister's office. We were moving into a 3-bedded room in the hospital. So, we've really matured, not just as healthcare providers, but also as a nation. And if you look at the overall statistics, we've been much better than the other countries. When we look at the Europe, when we look at America, I mean, we, initially we would very conveniently put it on the fact that we are Indians and we have a strong immunity, but, medically that makes no sense. So I believe that, we've really as a country reacted very maturely to this bit. And, there are small bits and pieces of episodes that happen here and there, but then it's something which has matured us as an industry. The only fear that I have at the back of my mind is that we as a race have a very short memory. And hence we tend not to learn from the mistakes that we make. So my only fear is that going forward, once we have a better control on the pandemic, we may tend to forget and get back into our thing, which is not going to be the right thing. We should always believe that there is a lifestyle change that is required. There's a change in the attitude towards hygiene that is required. And I visibly see a lot of ground zero reality, and hence I can confidently put it on the table that, we as Indians have, grown over a lot of things. We've suffered a lot, but we've grown over it.
No, I absolutely agree, and that change is visible, at every level of the society, in every section of the society. I mean, people volunteering to wear a mask in the villages, across sections of society, in itself is a big change. People washing hands, people sanitizing themselves. It is a gradual change, and I completely agree with you. People should not live with a short memory and should not put it on a back burner. I like the Cobra story a lot. Thank you for that story.
Great.
Go ahead.
Thanks, Arvind sir and Dr. Lall, for really setting the foundation for our discussion. Like you said, it's a long term. It's a long fight that we have, and that's what our focus today is going to be. How do we really tackle it? Whether it is digital technology or from overall strategic perspective. Now, I want to ask, a very, we know that everyone was caught unawares. This was totally unprecedented, and to say that the healthcare infrastructure is currently overburdened would be totally an understatement. So, can you just give us some insights into how this made you rethink healthcare delivery at the most fundamental level? Perhaps you might want to give some examples of some ingenious use of technology or digital that you had to come up with to quickly address or work around some of the unique challenges that you faced once the pandemic struck.
Shipra, necessity is the mother of invention. So you throw the situation on us and all of us will start swimming. I think that's a classic case of what has happened, and all of us are testament to it. Yes, I think the need, the fear of what was happening and what could happen. And once again, just going back to the very start of the conversation of the numbers and the statistics, while the numbers in India are indeed high, those in comparison with the density of population is a fantastic story for us. Because for us, it's about the density of what is the potential of what could have happened versus what we've come up with. I agree, still it is number 2 in the world or whatever it is, but that's fine. But the potential of what it was projected to be versus what we are currently, I think that is a success story. And that means that we've seen models. What do I mean by seen models? So temporarily, let's look at, forget the pandemic type thing. We had a situation where there was a lockdown and people still needed healthcare. So those who were discharged probably the day before the lockdown announcement or something like that still needed healthcare. They would have come in. There would have been somebody who's scheduled for a surgery in a certain manner, let's say the day after tomorrow, and they are going to be stuck. There are going to be people on dialysis, chemo, all sorts of continuous intervention type, though it is called elective surgery. It's really, I don't understand why it is called elective surgery, because I don't decide to have a heart surgery just because I think I have some free time on me. But that's English, so I'm going to leave that and not deliberate on that part of it. But they were all requiring direct care, direct intervention that was serious in nature. There were people whose diabetic medicine was being, checked out in certain combination to see whether the levels of sugar, their HbA1cs are in order, and they were looking at those. So they were, if I may say so, they were alternating medicines and figuring out what best to do. All these were happening. So people now immediately started looking at the data and started reaching out to them. So you had a good use of reach out, patient outreach, in a coordinated medical manner. When I say reach out, it's not just a marketing sales call without thing. It was a structured reach out with immediately an ability for a closure, because your window of closure is small. And please understand, those reaching out are also stuck in lockdown. You know, as lockdown happened, it took also the official machinery enough time to figure out who needs to be allowed on the road and who should not. So there was a period of time, even when the healthcare workers were having difficulty reaching workplaces, obviously because the administration also needed some time to react to almost everything that was thrown at them, also to be fair to administration and police and all of them. So that started looking seeing changing. Then, of course, the very big story that happened immediately is teleconsultation. So, obviously, till now, we have no laws on telemedicine. The general standard operating process was not there. So, I'm just not going to blame that there were no laws. I didn't do that. It's always easy for me to blame somebody else because I'm not involved. So, that's immediately we can jump to it. But then we immediately, I think the group got together and figured out how to make standard operating procedures. The beauty of this whole aspect, now forget the healthcare, what we saw in the other industries, instantaneous knowledge sharing, instantaneous ability where people came together, started working on this is a best practice of how we could do it. So hey, I could run an office this way. I'm not talking healthcare, but other people. I could. So knowledge sharing, and that means that knowledge is a repository and its power to run businesses. All those started improving. And then now coming back to teleconsultation, not only teleconsultation from an outpatient standpoint, you started maximizing your teleradiology, the telecardiology. Then we spoke about the ICUs. The ICUs needed ventilators and all of them. But tele-ICU, so that you're able to monitor other ICUs where you may not have that level of an intensivist as your larger hospitals that have the more qualified and the more senior intensivists who might have better experience in dealing with the situation that is presented, that experience factor also. So those started benefiting. And then the ability to use SMSs and such like methods. I'm talking now the frugal but still effective method of the mobile network. Starting to use that really effectively so that you start, communicating information. The real good use of social media in terms of communicating the do's, the don'ts, the hand wash, that whole 20-second hand wash, and lots of famous people, washing the hands and all of that. As much as we may want to make fun of it, at least let's be honest. Before this, we all didn't know that it was a 20-second hand wash. Please don't tell me any of us knew it. I didn't know it. Yes, I was in healthcare. I'm guilty of it. So let's not, just, Dr. Lall must be thinking, what the hell is this guy talking now? but we got to know, you got to wash your hands this way, and also it was very clearly mentioned that do it with normal soap. So you're not looking at some high caliber disinfectant or alcohol based disinfectant. That information transaction. So from a technology standpoint, that whole smack really came to living. You got your social, you got your mobile, you got analytics, you got the cloud, because data centers had to be running and business continuity had to happen and all. You got all of that going. So really smack, which was always talked about for the last I don't know how many years, suddenly became living. It was visible, though it was not called smack as we went through it in the last many months. All this happened. And then the whole aspect of productivity with collaboration. I understand this work from home could have caused other depression and things, but also look at productivity that could have happened. We've had all these online collaboration tools again for many years. And we started using it. We started becoming effectively productive. yes, there are side effects. I understand that aspect of. So I think all of this has put innovation in a reality standpoint. I'm not getting into just the other aspects of how a robo could do work, or how a robo could send food inside or medicine so that you avoid. In fact, yes, those were there, but I'm looking at something that is much more real, touch and feel, scalable, almost instantaneously, reasonable on the economic burden, if I may call it, in terms of what it costs to do something, not getting or sounding lost in what I think those are the aspects that I will feel more comfortable as technology, as process, as a society, that we have done better. And that is something that is a learning that should live long and not have a short life because of our memory issues to convenience. That is definitely there, but I think that's how I would put our scalability into innovation.
Very rightly said. I think, the last few months have been probably the biggest case study in SMAC across healthcare and everywhere else. So Dr. Lall, you also have also came up with a lot of quick solutions. For instance, I think you were talking about sensor-based systems which to maintain social distance. So any examples from your end, in terms of such quick solutions?
Oh, I mean, Arvind would love me for this, but technology has always been the Achilles heel of any healthcare organization, especially when it comes to adoption, because most of the times there is excellent production happening, but unfortunately the penetration of technology, especially into the clinical services, is always the Achilles heel of any healthcare organization. So this pandemic has actually taught those people who, and when I say those people, I talk about the senior doctors, the very senior folks who are the rocks of Gibraltar of any hospital system. This pandemic has actually taught those people that you need to move with time, because if you don't, then you don't stay that rock of Gibraltar anymore. So like never before have we seen the adoption of e-prescriptions, of using electronic medical records. So video consult was anyways a necessity in this pandemic. But before the pandemic, we used to really struggle to get our doctors to go in and even just log in, or rather type out the medications that are written to a patient. And we've seen a tremendous rise in acceptance and adaptability of these services, because today the doctors understand that if we don't do this, we no longer stay the big guys that we were. And with the advent of video consults, I remember we started very humble, where it used to be a very basic consult, and we used to struggle with our networks and connectivity issues. But over a period of time, very swiftly, our IT teams got on the job and made sure that all the leaks are plugged instantly, and they've been working 24/7. I think our information technology teams are working if not more, but at least as much as our critical care teams, and they've been facilitating all of that in the process. We've had, in fact, I've also seen a lot of innovation. As I spoke about the Cobra effect, I think that was the initial phase of the pandemic, when people could just think of sanitizers and masks. But when that did not work, people realized that boss, life has to go on. And then came in the real innovation in the industry, when people came up with such fantastic ideas, ideas like social distancing monitors. So we have some pilots that we did in our hospitals, where there were these monitors that were kept at 3 feet distance, which is now the WHO prescribed distance. And the moment OPD line would get violated in terms of distance, the buzzer would kind of it would just give out a buzzer. So this is so interesting, because as Arvind said, necessity is the mother of invention. If I didn't have to maintain that distance, I would never even have thought of those lines. And I think today that is the savior when it comes to, because at least OPD and public areas, because there is no other way I can control it. How much can a OPD coordinator or a security guard go and keep telling people to stay away? Talking about masks, I think the concept of screening desks had come up outside the hospitals, where there used to be a nursing team member at every entry and exit of the hospital who used to spray, check your temperature, etc., etc. From there, we've come a long way where now our hospitals actually have, automated sanitizer dispensers and automated sensors to check the fever. And, we've actually mapped it with the OPD registration. So if a patient comes in and does not, stand in front of the machine, which kind of senses the body temperature, he doesn't get to log into the OPD or maybe even the emergency. So, and people have fallen in line on that because we realized that how much manpower could we kind of, devote at every checkpoint. And then the double whammy was that our staff was also getting positive. People on duties were becoming positive and they were going for a 14 days quarantine, etc., etc. So I think we've come a long way on that front. So, and another thing I would give it to our patients is that they also started working towards the acceptance of technology, because initially when we started our video consults, most of our patients would just log in and then, talk to the doctor. And when the doctor would ask for the reports, they would have said that we don't have it or we've not uploaded it. That behavior change has come in now. Every patient is uploading his or her previous investigation reports, his or her TPA documents if the patient really needs an admission. And we've seen that behavior in the patients. They are, they are actually bearing with us for the overshooting of video consults happening. And, I think it's tremendous because saying that doctors don't accept it is a small part of it because that's by choice. But a patient is already in distress. And when a patient who has a cardiac follow-up is waiting for half an hour, 45 minutes for the doctor to connect, that half an hour actually feels like, hours together. I think that's something which has really, really helped us manage ourselves and our services in this pandemic. Apart from that, I also would give this to the Indian public, where I have now, for the first time in the technology era, seen people actually filtering information. Today we have so many channels and so much of wrong information flows here and there. But if you analyze an end-to-end situation, obviously exceptions are always there. But if you analyze the end-to-end situation, we have actually got into the habit of filtering the information coming to us from social media platforms based on common sense. A lot of information that comes to us, we say, "Nahin, this is not true. Yeah, we read this over there. This can't happen. The doctor said this." Initially, we used to always complain that, patients Google up and come to the OPDs and then they tell the doctor that, you must be wrong because Google says this. We've seen a reverse psychology play over here where people have now started trusting the healthcare providers, and based on that common sense, they've started filtering information flow that is happening. So, I was sitting in a meeting the other day, and somebody just mentioned that there is there is something coming across, there is a vaccine that is coming across, but then people just snubbed the person saying that this is all hearsay and there is no evidence, and somebody came up saying that there was a study and this and that. So, and this is the normal people who are not medical people. So I think that is something I would give it to the patients today, where they have actually gathered themselves and taken it upon themselves to make sure that each one is responsible for, ensuring that we handle this situation well. And last but by no means the least is the use of, video conferences. So initially what used to happen is at a pan organization level, we used to definitely get onto calls. But today I see my departments using it. So there's a doctor who's doing an OPD, there's a doctor in the OT waiting for the OT to get free, there's a doctor who's in the doctor's lounge, and there is a cardiothoracic surgery meeting. Instead of getting into a room for social distancing issues, they are all logging in from their own phones, from their own hand phones, and they are having a meeting at a time when they would never expect to get together. So, I mean, to arrange a departmental meeting, it would take something like a week for us to identify a slot which works for everyone. But today, for a 15, 20 minute or half an hour discussion, people just step out of the OPD and say, yeah, my patients are not there. I have the next appointment half an hour later, or the OT is overshot. The last case is, it's overshot. So let me just join the meeting and figure that out. And it's so much more productive. So I think, we've really showed a lot of resilience on the technology front, a lot of acceptance and adoption on the technology front. And this time, so Max Healthcare is always part of the main medical sponsors for Airtel Half Marathon. This time we actually did a virtual marathon. Airtel's gave a link to everyone, and everybody ran in their own neighborhoods, and that's how the marathon happened. So it's amazing the way, and trust me, the kind of scale that you can get with this virtual adoption is the next level. I mean, normally something like 10,000 people would register. This time, I'm sure, multiples of 10,000 registered, because it's more convenient, it saves more time, it is logistically more easy to manage, it is cost effective. So I think, we've really understood the real essence of how technology, can be used as a service, the SaaS concept of SaaS. I think we've really understood that in this pandemic, and I hope we continue to work on those, innovative and out of the box concepts.
I can really see the passion that both you and Arvind have brought into this conversation, and I think
the only difference is Arvind is in the driving seat.
You are no less, you are a co-pilot too, because it's between the stakeholders that you play the role. Yeah, so if I stay on this topic of capacity building, I think that's a very fascinating topic. It's not necessary to always have the capacity in the most conventional ways. And since we are talking about technology, since we are talking about digital enablement, I think it is the opportune time to also nudge the technology industry, the technology ecosystem, whether it is the large big tech behemoths, or it is the new startups which are doing a fantastic job of coming up with cutting edge stuff, using, even if it is about using 3D, using IoT, using artificial intelligence. I think some of these startups are coming up with remarkable things. Also aligning it with the National Digital Health Mission, which was announced by the government very recently. So Arvind, what do you think? How is this capacity building? Does the capacity building happen without going on to the conventional ways of building, large hospital infrastructure, putting beds into it, and then waiting for eternal time to, have them operational?
Here is where you're looking at the power of digital solutions. And you're also looking at the power of digital solutions coming up with really innovative business models. So in a physical manner, when you're looking at capacity building, you're looking at partnering with some of the hotel industry team members and creating those isolation beds of people who are in a certain medical condition, who can be kept in such like places, plus giving cognizance to the fact that they may not have caregivers in their homes, and hence they need somebody to take care of them because they are in a little bit of a vulnerable position, but not so medically vulnerable. So now here hospitals are partnering with hotels, and you are using digital technologies to monitor these less vulnerable patients by those who are not fully medical, like the team members in a hotel may not be fully medically equipped, but they are able to execute certain instructions. Thereby they are able to channelize that whole care process. So you're building talent with instruction based talent, and you're making sure that things can work. So that is one aspect of technology assisted capacity building. The second aspect is definitely using all these various types of monitoring IoT devices that are connected to the patient health record, that translate into the electronic medical record, like the systems that Apollo has got in terms of the PHR, the 24/7 mobile solutions that are there for consultation, and the Apollo Sting mobile, the medical response centers and all of those. So those help people to be monitored. while they may not necessarily need to come into the hospital, again, not necessarily they are pandemic affected, but they may also have other health needs that need continuous health support. And many a times it may not be a health condition, but all of us think something is wrong, or we get worried about something being wrong, and we need some medical assurance. Not always I may want to call it medical condition, meaning they may be having something, but when a medically qualified person talks to them. So that is where you're looking. Now, put all of this in the perspective of the NDHL. What is it the government trying to create? They're trying to create a health ID. You have a health ID so that each person is able to code that, and you're able to interoperate your records wherever you are in India, so that your care continuum is comfortable. And in India, you have people coming to various entities for various aspects of care. Somebody might come to Apollo for cardiac care, and the same person for their general medicine needs may go to Max. And it is very important that the Apollo doctor knows what the Max doctor for the same patient, and it could be just common flu. I'm not talking of some severe illness, but from a continuum of care. Okay, why did you go to Max continuously saying you were feeling tired or flu-like symptoms? Is a good clue point for the cardiologist to figure out why this guy is feeling tired. And so there is, because probably the Max is closer to his house and the doctor is known and it's quickly there. But look at the continuum of care. The doctor in Apollo will be able to quickly figure out that this guy is getting fatigued very fast. I think he needs to be put into some sort of a diagnostic intervention to figure out why, because this sort of a fatigue or the so-called flu-like symptom is not looking normal for whatever his age, condition, and situation might be. Now you're looking at this continuum of care. With a health ID, you're looking at interoperability of this information. Obviously, everything comes with consent. It comes with fair realm of privacy and security, and that needs to be very well tested, orchestrated, designed, made sure that there are no loopholes or flaws. That's very, very important. So the whole aspect of privacy and security is a given. It's not a side step. So it's the fundamental block, and all this conversation, so I'm taking that as a given and not elaborating on that aspect. And everything is based on consent also. So you're looking at really effective and successful interoperability of record. And thereby, when you create a health information exchange at a national level and the private health information exchange at various cohort levels can be hospital based, it can be condition based, all of that, you have a really thriving ecosystem. And this thriving ecosystem can start generating the data and insights that will give better protocols, pathways, evidence-based medicine that will do well for the Indian population. It can definitely help the global population, no doubt, but we will know something that's bang on, applicable to us directly at point of care. All of this, when you put together, you are looking at ultimately speed to diagnosis. That means that we are able to identify what's wrong and get the person into a quick pathway and a protocol, a care protocol or a care process. And that way he is getting into treatment and thereby on his course of getting well and getting close to normal or normal as quickly as possible. So that means you are speed to diagnosis quicker. The treatment plan shorter, faster, effective. And this is a combination of diagnostic, it is a combination of medication patterns, it is a combination of also other allied health patterns. Again, COVID is a great example of allied health patterns. You're talking about warm water, you're talking about gargling with mint water, and all things that we are normally used to as a society. So mint is not something unusual to us, or any of the green tea or lemon tea or any of those aspects are not unusual to us from our normal society patterns at any strata of our society. It's not. So you're adding all of that. You're adding the ability to exercise and the physiotherapy aspects. So allied health, dietary aspects, normal vitamin C and all that stuff. Okay, you know what? If I'm sounding too complex with a vitamin C, a good Nagpur orange is more than enough. That's we like that. We can gobble up any amount of that, and we've been doing it. I don't know how many of you can, fall for a mango, but I can. so, so all of that are part of our practice. So all of this comes together. That means collaborative medicine. Collaborative medicine powered by knowledge and intelligence, powered by technology that ensures that this is sustainable 24/7, trustworthy. Your knowledge levels are the same. So you have a thriving ecosystem. I think all of this put together is how we will see success out of the proposed NDHM model. It's just not some law of the government or something. No, the government has started something. It's a platform. It's a platform for us to thrive on. I think we need to pick it up and start making it effective. The government can lead, the government can nudge, the government can do a little bit of activities to get you jump started. There can be a carrot and stick approach and all those things. All this with an intent of jump starting something. But ultimately, it's for all of us. And this is not necessarily true only for private healthcare. This is true for all formats of healthcare. It's about healthcare. What is the funding source of your healthcare? Is public healthcare, private healthcare, so on and so forth. That's got nothing to do in this context. Once you do that, I think the government's NDHM model can be put to effective use. Yes, there are some teething issues. Yes, there are some unanswered questions. Yes, there are certain ambiguous aspects of it. I think, you know what, we got to break it up, discuss it, because our intent is not to make a mistake. And definitely our intent is not to make a large scale mistake. So there is a problem, there is an unambiguous, or there's a perception. It may not be unambiguous, but somebody thinks something is not okay. Bring it out in the open, discuss it, make sure that there is enough trust created around the truth of the answer and not the perception of the answer. And that's where you can start using various communication, knowledge management solutions, collaboration methods, so that you are not breaking from reality. That, when you put into the government's NDHM model, will start bringing not only capacity aspects into healthcare, but also that level of sustainability and scale, because India needs scale. And talent levels, we don't have that many people, though we are a land of 1 billion people. We don't have that many.
By the way, are you part of this mission in any way? Are you consulting? I by the way you are talking, I feel that you are.
Yes, definitely. Yes, been talking regularly to the NDHM team members in trying to figure out how we could join, partner, and help. And in the past, of course, worked with a lot of the government groups in terms of making these EMR adoption, guidelines, and some of the guidelines around the Disha Act and all of those as part of the industry body that is really helping out. Not really that I'm affiliated to any of the government. Nope. If you're going in the direction, nope, I'm not.
I understand. It has happened in certain cases. Those cases may not be the similar, but it has happened in the same gigantic proportions. For example, giving a CIBIL score to a citizen and sharing it across the financial sector companies. That was a behemoth task which actually got accomplished. So, Dr. Lall, capacity building from your perspective, Arvind gave a very, very passionate answer to it. Capacity building from your perspective, and especially, how do we include the ecosystem which is not conventional, as I asked Arvind as well. So not conventional ecosystem, not depending only on the known entities, also getting into play the newer entities.
So, I mean, in the interest of the audience and very contrary to what the common belief is, Fortunately or unfortunately, organizations in healthcare have always been very, very amicable and have been talking to each other in terms of clinical help and collaboration ever since they started. Obviously, Apollo started much before the other corporate organizations like ours came in. But fortunately or unfortunately, we've all been pushed to capacity building because there were enough people who needed medical care, and not just at the organization level, but also at the doctor level and at the ambulance level. All major organizations in a geography talk to each other and collaborate and work together and share partially talent in terms of clinical talent, etc., etc. So all of that has always happened because we've always been full. Beds have always been an issue. This is the first time it has been highlighted because people, the media highlighted the non-availability of beds. But if we talk about major hospitals in every city, even in non-pandemic times, getting a bed was not, a cakewalk for sure. And hence, capacity building has always been, and the reason I mentioned this is capacity building has always been one of the, proactive areas of interest of all major organizations in the healthcare space in India. Even today, when we have emergencies that are completely full, the lowest rung of doctors are connected not just with corporate hospitals, but government hospitals and smaller nursing homes in the geography. And we, or rather every hospital, facilitates the patient to some hospital in the neighborhood which is capable enough to manage that situation. And very few people, or rather minuscule percentage of people in the city or in the country are dying because they don't get emergency care that is required. In our emergency today, since the hospital is full, we are doing plasma therapies in the emergency itself. We are doing remdesivir in the emergencies. We are putting vents on patients in the emergencies because the ICU beds are not available. And as and when we keep getting information from the neighborhood hospitals, doctors have colleagues across the geography, and that's how the capacity manages. Just to give you a small example, there are a lot of referrals that happen cross states also. So for example, a lot of patients are referred to Tata Memorial Hospital, Bombay from Delhi. A lot of patients from East India are referred to us for transplants. Apollo Hospital has been here for a while and has developed a beautiful range of services. So I think that capacity building intent has always existed, but what has been missing has been the innovation piece over here. It has always been very conventional because till today, till the pandemic started, we always could manage. When the pandemic came in, there was a double whammy that happened. One was more patients needed hospital beds, and the second was that we were stripped of hospital beds to be dedicated to COVID patients, even if there were no patients in those beds. And unfortunately, a ward which has a single COVID patient cannot be used for any other patient. That's the nature of the disease. So this double whammy taught us that we need to bring in innovation into our capacity building, and it is not enough to manually coordinate amongst ourselves and make sure that patients get a bed. So if we talk about the mortality rates of COVID patients, it's very low. It's just about 1.8%, and that was also in the worst phase, which is nothing. But unfortunately, in every organization, in every healthcare organization or hospital, there are many, many more patients dying of non-COVID diseases. There are patients dying of strokes. There are patients dying of cardiac symptoms. And that is something we are overlooking at that point in time. And that is, to be honest, that is where the capacity building is required. Because today, if a COVID patient doesn't get a bed for 2 more days, barring apart the severe cases, the chances of that patient's mortality is very, very minuscule as compared to a patient who has a cardiac arrest, who needs a emergency cardiac surgery, a CABG. So we are, from our perspective, I think more attention. We've done enough on the COVID front, but more attention needs to be paid on how we manage mortality is happening due to non-COVID reasons. And that is an area which is completely ignored at this point in time, because obviously, you know, in a pandemic situation, anybody like me talking about non-COVID stuff is tagged as an idiot. There are many better things for the media to kind of, you know, bring to light, and that's what people want. But unfortunately, you know, the reality lies a little away from what we're talking about. But some, I mean, I don't want to sound negative, but some good things that have happened here is the use of technology and the use of unconventional methods of capacity building. And the largest bucket that I have seen growing has been home care services. You know, this is the first time I have seen patients accepting home care services, accepting physiotherapies at home. Physiotherapy was still happening, but at least accepting critical care at home, accepting oxygen therapy at home, accepting video consults with the doctor and follow through home care services. So that's the real capacity building, because see, in a country of multiple billions of people, I think we will never in our lifetime be able to reach a situation where we have enough number of beds and enough number of doctors and staff who are qualified. The talent pool will never grow to a level where we'll be able to cater to every single person in this country. And hence we need to start pushing these. A lot of them are startups. I think we need to start giving them platforms. Organizations like Apollo and ours, we do our own home care services. So when we talk about continuity of care, today I am discharging patients from my ICU and giving ward coverage at home. In a normal situation, I would discharge a patient from the ICU, take the patient into a ward, have a higher average length of stay, and then discharge the patient home. Today, I am actually cutting out my stay in the ward because I technically don't have ward beds. You know, X number of beds have been dedicated to COVID wards, and hence I am discharging patients from ICUs, and they are following through the continuity of care at home by, you know, nursing care at home. Wounds are being, you know, for wound dressings, patients are not held back in hospitals. Nurses are actually going in and doing procedures at home. The drips are getting done at home. Oxygens are at home. So this time, the third wave has actually given us a little bit of liberty to manage more critical patients, because the less critical ones are already taking oxygen at home. I mean, I know of every fifth COVID patient who's been doing 4 to 5 liters of oxygen at home, and when the oxygen requirement increased, then they came to the hospital. And I then have a bed to offer a more critical patient rather than having, you know, a patient who didn't need a bed. Also, you know, my understanding on innovation doesn't stop with process-oriented things. In fact, I would say that it is about how flexible we can be as medical organizations. So an example that comes to the top of my head is that when we were designing our COVID ward, obviously a single room has a patient's bed and an attendant's bed. In a COVID ward, an attendant bed doesn't make sense because attendants cannot enter a COVID ward. So we converted those attendant beds into normal patient beds. So that meant that a single room was converted into a double room. A 4-seater room was done into a 6-seater room. And, you know, there was much better utilization of real estate. So that's one. And the second thing now came in is that in a room which has 2 beds, one bed has an oxygen manifold because that was supposed to be the patient bed, but now what happens to the other bed? So very innovatively, our biomedical engineering team did multiple things. One was that we actually had drop-down oxygen panels, you know, for emergencies in our corridors. So today in our wards, if any normal patient who is on room air requires oxygen, we have recliners in the lobby areas, and there are makeshift drop-down oxygen panels. It's almost like an aircraft where, you know, you get into a zone where the oxygen goes down and something falls from the top. So we've actually innovatively replicated that in a way that if any patient who's on room air suddenly requires 2, 3, 4 liters of oxygen, he's taken to the recliner. Instead of putting him on a bed, we've efficiently utilized real estate. We put him on a recliner and given an oxygen mask or maybe even nasal prongs. The other thing that our biomedical engineering team did, and it was actually national news, was that they created Y switches which were put onto ventilators. So one ventilator could cater to 3 different patients. There were 2 schools of thought over here where, some people came in and said that it is not acceptable from a JCI. We are a JCI accredited hospital, so not acceptable according to JCI, left, right, center. At this point in time, all of our focus is very clear. We have to save lives. So we have actually gone in to improvise on those models and make them so efficient that today, in spite of having a vice switch, I have also introduced a regulator in that tube where a single gas manifold can cater to 3 different patients, and we can give 3 different levels of oxygen to all 3 patients. And trust me, this innovation came in only because we got into a situation where we realized that, we had 100 patients, but only in that ward, probably only about 40, 30 ventilators. So that's how, the industry is changing. And I always keep giving this example to my teams that we in healthcare always required what happened in international cricket. When we were kids, we used to have these 5-day matches and we used to go and sit there through the 5 days. Then we started working and time was an issue. So we said that let's go on to one-day internationals. The one-day international would go through the day. And then we got into healthcare. Arvind, you'll agree with me. And hence we didn't even have that much time. So now the T20s came in. T20 strategically starts at 6 o'clock in the evening and ends at 11 in the night. So, a person goes to work, gets free at 5. We don't, by the way. So, but the person gets free at 5 and then goes to watch a match at 6 o'clock and 11, he is back home. So that is exactly what is happening in healthcare. We have now learned that the only way to survive in this highly competitive, price-oriented, financially driven, excellence and quality-driven market is to be more and more efficient like the Indigos of the world, where, we've started replicating the web check-in of an airline to the admission process of the hospital, where we send a link to the patient actually uploads his insurance documents from home. So rather than waiting for 2 hours in the hospital and then getting admitted, the guy does everything at home and comes and gets admitted in 15 minutes. That's the process excellence that we've got into. The last but not the least on capacity building, I actually would like to give it to the allied industries, wherein a lot of industries pitched into healthcare, like the automobile industry, etc., and they started manufacturing ventilators. It is such a revolutionary thought, at least in a country and an industry that we come from, where the automobile industry realized that, cars are not going out, let's make ventilators. Obviously, ROIs need to be factored in. Obviously, cost sustainability needs to be factored in. But at least we are now looking at cross-functional usage. So it was amazing the way the automobile industry came in. It was amazing how hotels opened. I mean, we had 4 major hotels in the national capital which were tagged to our hospitals. And trust me, they were all full, and thousands and thousands of lives got saved because of this pitch-in that happened. In fact, even today, a lot of hotels, they give us their accommodations for our doctors and nurses and, back-end staff who are in COVID duties. So I think that's about capacity building. We can build enough hospitals and enough beds in this country, but I think it needs to come in with innovation and open mind, and the fact that what is impossible today can actually be made possible tomorrow. So I think that's my piece on capacity building.
Fantastic examples.
Add to what Dr. Lall was saying, it's also bringing in a beautiful way by which the resource capacity is built in terms of the human resources. Because as we speak about the patients and all the other, we forgot about our doctors and nurses who are fatigued, who are working tirelessly. Doctors, nurses, the medical technicians who are working behind and how they were, rotated, also protected, because they are equally susceptible to the virus and conditions, including, a little mental state of condition also, because you're always looking at sadness and uncomfortable information all around. And so how that was also done, I think it talks about how organizations, all types of organizations, again, private and public, worked on resourcing so that the short pool of staff that they had could be used as much as possible so that yes, we were always talking about bed shortage and ventilator shortage and all of that, but touch wood, we did not get into medical personnel shortage, because I think there was good care, and we should continue to keep our precious commodity well protected, because they are very important to all of us, and they're doing such a tremendous job, the medical community, in terms of all of the activities, all the allied caregivers who are doing such a fantastic job, and they are also short in number. So I think that resourcing model is also something that is worth understanding, digesting, replicating, and living continuously. That's added to the other innovations that Dr. Lal was mentioning.
I think
Great. I think
and I'm sorry, I'm pitching in. The week had conducted a very major story which covered all major service providers, healthcare service providers last week. And by conclusion, the same thing that happened in the Kargil war actually happened in the pandemic, where there was a complete intelligence failure, but the dedication and passion of our soldiers got us Kargil. The same thing I would say happened in healthcare, because I have we were in a double whammy where we didn't know how to handle it. There were no trends on how the pandemic is going on. The shift in a PPE is actually legally 6 hours as opposed to the 8 hours that the labor laws allow. But still, the passion of our staff members has been unimaginable. And unfortunately or fortunately, people who fell sick, I have had doctors and nurses who fell sick and were admitted in the wards, actually taking actual rounds of the patients. They said that we are fine, we're taking room air, so they might as well take a round and see if any patient needs a cannulation. So I think that's something, we hats off to these guys. They've been on the front, and we've been led by them completely.
Absolutely, hats off to all the.
Yeah, I think it's time to actually show the gratitude to the healthcare workers, because I can understand, not just during the pandemic time, otherwise as well, they are dealing with patients, and dealing with patients cannot, you overtly cannot be very positive while doing that job. It's very easy for an outsider to go and start yelling at any staffer, and which I have seen personally in many cases, in the hospital, and get annoyed because of slight delay in certain things. However, if one has to understand their psyche, and if one has to understand what they are going through, I think it's a very different deal. It's a very different world. The focus was not that, but Dr. Lal, the biomedical innovations that you talked about are phenomenal. I must really congratulate you and all other hospitals who did this. I mean, who could have thought that a patient can sit on a recliner and take oxygen, for which usually people take wards, occupy wards. The discussion can go on and on, but I think in very less amount of questions, you guys have covered a tremendous deal of wisdom. And I really thank both of you for your time. I'm sure it's very precious to both of you. Dr. Lal, you are in the hospital. You told me you are doing a double shift. So I'm sorry to keep you waiting for that. Arvind, same here.
Arvind is the tech man. He's just put a background. He's also in the hospital, by the way.
The power of digital, you have a good background there.
No, great talking to both of you. I really appreciate your candid conversations, and I hope our listeners also benefited a lot from this. I will personally give you some feedback once I collate that feedback. Thank you very much, and have a very nice evening.
Thank you. It was awesome listening to both of you and the innovations that you spoke about. I just hope that unfortunately it had to be a pandemic-like situation to bring those innovations out. But yeah, like you said initially, we should not have a short-term memory, and let's not forget about all these innovations that we have undertaken today. Thank you so much. Pleasure talking to both of you. Thank you.
Take care. Thank you so much for having us.
Thank you very much.
Thank you to all our viewers. Thanks. Bye.